persons, friends, the outset I'd like to thank Hoya for putting together this symposium. Can I? Yeah. The topic given to me is IPCL, my experience. Relevant to this particular presentation is that I am a speaker for both STAR and IOCare. Actually, my experience with phakic intraocular lens started with VeriSize between 2002 to 2006. Then almost for 6 to 7 years I was using ICLs exclusively, and later on I've been using the IPCL also. Today I use both these lenses almost in equal measure and equally happy with both of them, and I'll be sharing you my experience with IPCL. So many of you are aware of the ICL, and they have also come up with a new upgraded version called the ICL Evo, and what we have in IPCL is the version 1, and now we have the version 2. To compare the features of the two of these lenses, as far as the dioptric range is concerned, ICL is never customized. It's from +10 to -18 spectacle power, and here IPCL +15 to -30 you have almost off the shelf. And of course some extremes of power might take a little longer to get. Astigmatism is up to 6 diopter correction is what is possible in ICL. With IPCL is almost up to 8 diopters you can get. The material is Collamer, which has a long history of stability in the sulcus, and in IPCL it's a modified hydrophilic acrylic. Initially I had some reservations about this, whether it's the ideal material for putting the sulcus with the natural lens in place. But this lens already is being implanted in thousands of eyes, not just in India but elsewhere. In my own experience itself, this doesn't seem to have had any deleterious effect. But this is something we need to look out for, and then maybe over the years we'll gain greater confidence with this. As far as the number of holes are concerned, we have one central hole of 360 microns in the ICL and 2 paracentral holes. And with the IPCL, it's a 400 micron hole, and the configuration of the hole is such that it's a little broader outside, and it narrows down as you go in. And apart from that, there are a couple of holes here just at the edge of the optics, and these para-optic holes are there. And all the 4 haptics, it actually has 6 haptics, all these edges have fairly large openings. It is said to allow free circulation of fluid from the back of the lens to the anteriorly. This also lessens the mass of the lens, because of which even if there are minor inadequacies in the sizing of the lens tries to settle down and does not cause excessive vaulting, and I think that is a great idea. But of course this makes it a little difficult. Initially when this lens was brought in, it was only the leading left haptic and the trailing right haptic which had holes, so it was easy to identify. Now they have a small protrusion here and a small dent over here, but when you are aiming at keeping these two on the upper end, then usually you get the lens opening up the right way. But maybe having a better marking than what they are presently having would be a good idea. And now since both these lenses are coming with a central hole, a peripheral iodotomy is not really required. And this lens has 6 haptics compared to the 4 in the IPCL, and maybe giving better stability to this lens. And the ICL, especially the toric version, they do only have it at certain powers, and since it's imported, it takes some time to come, and all these lenses have to dialed into place. Of course they have a chart accompanying which tells you whether it's 11 degrees, 15 degrees, sometimes even 17 degrees. But the good thing about the IPCL is each and every toric lens is customized so that it's at exactly 180 degrees is what you need to place, and that makes it easier. I already mentioned about the size of the holes, and the hole in all 4 haptics, and it's dispensed in BSS. As far as ICL, it is dispensed in saline, so there's a little propensity for the lens to enlarge after implanting. The loading is quite different as far as the ICL is concerned. You have to get comfortable with that. While with the IPCL, it's very similar to plate haptic IOL. So in case you have used some of the plate haptic intraocular lenses, adapting to these lenses would be quite easy. As far as the size itself is concerned, I think there's a great advantage as far as the IPCL is concerned. For a long time, ICL used to come only in 4.9 to 5.8. Now, for some of the smaller powers with the EVO version, they come up to 6.1 millimeter. We must remember that the optic zone size that we get on the cornea is about 1.25 times. So, when you have a 6 millimeter optic, it almost corresponds to a 7.5 millimeter optic zone size for a laser vision correction. On the other hand, with the IPCL, you have, even for a long time, we have had a 6.2 millimeters available. And in case you are coming across large scotopic pupils, the custom-made lenses have even these larger optic size without increasing the overall size of the lenses available. So I think that's a great advantage. And when you have large scotopic pupils of, say, 6-7 millimeters, getting a customized lens so that dysphotopsia from the edges of the lens is avoided is a good idea. Just to show you a short clipping of loading of these lenses and implantation, you can see it's a good idea to use just normal saline. Initially it was a little bit of methyl cellulose and normal saline. Now I use only normal saline. Actually my sisters are quite adept at loading it and giving it to me. And you just place the lens in the ledge and keep it in one of them and then introduce it into the other. Then you have to push the lens to the edge of the cartridge and press down on the lens while closing it, and that ensures that none of the lens gets stuck. And then it's just like you have a injector, and it's very similar to what you use with the intraocular lenses, and that's a paraffin being injected. It's that 90-180 that we make the incision. I usually make a 3 to 3.1 millimeter incision because I do not want a wound assisted implantation, and that gives me better control as far as low implantation of these lenses is concerned. And it's only for the last 3 or 4 months that the lens with the central hole has become available. This is a slightly older video, so you won't see a central hole in that, but in all other respects the lens is quite similar. And this is a toric markings on the lens. There's a fairly large optics of the lens. And you can see these two holes has to be always on the upper side, and it's always injected into the anterior chamber, then gently nudged into place over here. And you can see the lens being positioned behind the pupil. Just in case the pupil is widely dilated, then it's a good idea to burp out a little bit of viscoelastic so that the pupil comes down, and that helps you to position the lenses properly. Nowadays I use high molecular weight viscoelastic like Helon, and after placing the lens in position, when I inflate the incision, then the entire viscoelastic just gets burped out. Otherwise you have to remove all the viscoelastic completely. I think I'm going to skip these couple of slides because I think the subsequent speakers will be dealing with that. But I essentially want to share our experience of about 3 years using the IPCL, and it's a retrospective analysis. The period of study is from August 2014 to May 2017. We started using these lenses then. The total number of toric IPCL is about 134 and spherical IPCL about 35. 80% of the lenses that we use are in toric, and I think that's important because even though the patient ends up spending a little extra money, it's important that you tend to correct any cylinder beyond 0.5 diopters, because otherwise they are unhappy with the residual cylinder. And the hyperopic eyes, though a wide range is available, only 2 eyes have been hyperopic eyes. And I thought most of the patients we do are bilateral, but I was quite surprised to see that there's a slight predominance of right eyes, and that of course has no clinical significance. And as far as 60% nearly females and about 40% male patients. And the indications, as I said, 150 myopia, just 2 eyes of hyperopia, and most importantly, keratoconus. Once it is stable, whether because of collagen cross-linkage or because of the age of the patient, 21 of these patients in this particular analysis were patients with keratoconus, post-classic in 4 eyes and post-keratoplasty in 1 eye. And as far as the age distribution, as expected, 80% of the eyes belong to the 18 to 27 age group, and even the extremes of age, some of them even at the age of 35, 40, we have done a couple of eyes. Range of sphere up to about minus 21 diopters, and you can see up to 6 diopters of cylinder also have been corrected, and this lens can be customized up to about 23.25 is what we have used, but even a higher range of power can be custom made. As far the results were extremely satisfactory. We had analysis for all 134 eyes for 6 weeks, for 113 eyes for 6 months. And what we found was the mean sphere was just 0.127. And the stability was also extremely good, that over a period of further follow-up, there was no significant change in the residual error, and that the same thing applied to cylinder. So the kind of correction, of course, the mean spherical equivalent and outliers would be there, was very satisfactory, and you see that the lenses have been functioning quite well. And as far as change in lines, the preoperative best corrected visual acuity to postoperative uncorrected visual acuity, which tells you the efficiency of these lenses. 110 of these eyes maintained the visual acuity, while about 43 eyes did show an improvement, and this is expected when you're especially correcting higher grades of myopia. Many of these eyes belong to the keratoconus group. I'll briefly dwell on that. And as far as preoperative best corrected to postoperative best corrected visual acuity is concerned, which is important from the safety angle, majority of these eyes maintained good visual acuity. It was only 4 of these eyes which lost 2 lines, and all these eyes belong to the keratoconus group. And and as far as safety is concerned, at 6 months again, the results were quite good. And repositioning was required in 8 of these eyes. And mind you, my tolerance for repositioning is quite low. Even if the patient has minus 0.5 with a plus 0.1 diopter of cylinder, I go ahead and reposition these lenses. And especially since there are a significant number of keratoconus cases where determination of the exact refractive error itself is a challenge, some of these eyes did require repositioning. That was about 6%. I would say that it's important that we reposition these lenses to get optimal outcomes, and especially if the spherical equivalent of the residual error is almost 0, these patients seem to do quite well. And we had to explant one eye because of high intraocular pressure, and otherwise these are some of the minor complications that we faced in the postoperative day 1. All of them could be managed clinically with medical treatment. Again, complications at 6 weeks, IOL rotation in 8 eyes, raised intraocular pressure which could be medically controlled, and cataract, small paracentral opacities, none of them were impairing vision. Very quickly, I know my time is up. Keratoconus 21 eyes, and many of them had significant cylinder, and you can see that the correction even in these group of patients was extremely gratifying. Of course, in these patients you do not promise refractive accuracy, but debulking is what you promise. Essentially, as far as these patients are subjected either to a turbo-guided PRK or intact segments so as to make the cone quite central, and then subsequently these toric ICLs are implanted, and significant number of them experienced a gain in vision. So basically the thought I want to leave you behind is that implantation of IPCL is a safe and effective procedure for good refractive correction for myopia, hyperopia and astigmatism, and in stabilized centered keratoconus patients also. I think it's good to have the freedom of choice, and phakic IOLs have come to stay as a significant armamentarium in a modern day refractive surgeon, and this is a very cost effective solution which is readily available to us. I think we would do well to adapt this. Thank you so much for your kind attention.